Okay, yeah, thank you, Nifemi. Good evening, everyone. My name is David Ikeneke. I'm a cardio-thoracic trainee, as Nifemi said, at Papworth. Um, I'd also shamelessly talk about our endeavour, which is called the London School of Cardiothoracics, um, which we set up about 3.5 years ago in with a couple of my colleagues and a couple of consultants here in the UK. And this is why we set it up, because we would like to improve surgical training, specifically cardiothoracic surgical training, not only in the UK but abroad as well, with specific, should I say, with specific focus on uh, creating a sort of equitable provision of cardiothoracic training for everyone who's interested in this wonderful specialty. Thank you, Femi, for having me today. And we are going to be talking about cardiac physiology. Now, when Nifemi asked me to present on cardiac physiology, the first thing I thought is this should be a cardiologist. Why should a cardiac surgeon be talking about cardiac physiology? Um, and that's because at first I was looking at it from a very bookish point of view. What are the values? What are the timings? Cardiac action potentials, things like that. And I thought to myself, we never really think about this as cardiac surgeons. However, I was wrong, because if you surgery is one of the few surgical specialties that calls its surgeons to be not only surgeons and good with their hands, but also good with your brain in terms of your clinical approach to the management of your patients. At every stage of your journey, of the patient's journey, you are managing the patient clinically with robust input of their physiology, anatomy, pathophysiology, and all of these things will come together through your various investigations and tests to determine how you'll proceed with the treatment of the patient. And so, with that in mind, and having corrected my initial error, I started to think about how I could talk about cardiac physiology to cardiothoracic surgeons, junior surgeons, as I've been told, as I'm a junior surgeon as well. And I think about the application of cardiac physiology to our day to day practice. And therefore, I decided that I wasn't going to come here and wax lyrical on these special numbers, because you can read that from a textbook. I'd rather want us to have a discussion on how cardiac physiology impacts our clinical decision making. We'll start off by just an overview and remind ourselves of key concepts, and then start to tackle the preoperative and postoperative period of our patients. And unfortunately, we can't go into depth in terms of dividing the patients into ischemic heart disease, valvular pathologies, arrhythmias, and so on. But what we can do is we can have a sort of overview of the cardiac patient. And where necessary, I will be specific. And where we can't, for the benefit of time, I'll just talk about the patient, the cardiac patient, as a holistic view. And so, moving on from that, we divide in this session into pre-op and post-op. We're looking at disease physiology, operative physiology, post-op physiology, and complications. So we're looking at cardiac physiology, and then we're thinking about how does this affect our clinical decision making when we are looking at the pathway or the journey of the patient, starting from presentation of the disease to or the operative period, the post-operative management, and finally complications that may arise. Going ahead and tackling it this way means that I wouldn't have time. I do not believe multiple studies have shown that the maximum attention span for anyone is about 40 minutes. And given that we've had a bit of a late start, I've created this slide so that I can hit 30 minutes. I'm hoping to finish this in 30 to 35 minutes. I would like this to be an interactive session, so I've kindly asked Nifemi I will be asking questions, and I will appreciate if there can be some sort of response on the chat system. And so, in order to test this, I'll start off by saying, can everyone hear me? And can just random people post yes or no? So that because I haven't used Medall before, so I'd like to know if people are actually there listening in terms of using the chat function. So can someone just post a random yes or no on the chat? Oh, brilliant. Thank you. Okay, so moving on, we'll start off from cardiovascular anatomy. And this is, thank you, everyone. Thank you, everyone. I can see that. Brilliant. Okay, so we'll start off from cardiovascular anatomy because we can't start talking about physiology without talking about the heart itself. You all definitely know the anatomy of the heart, so we'll move on to why I'm talking about cardiovascular anatomy at this moment. My next slide will make things clearer. But the flow of blood, so the flow of blood, it's chicken and the egg situation. Some people like to start from the lungs. Some people like to start from the aorta. Some people like to, and so it really depends on your preference. I think that if we're talking about blood flow, we should really be starting from the point of oxygenated blood, and that's when blood has left the lungs through the pulmonary veins, going into the left atrium, going past the mitral valve into the left ventricle in diastole, going into the aortic valve, going into the aorta in systole, then going around the blood, the human body, branching off into major arteries, which become arterioles, capillaries, and then finally going into the venous system and going into the superior and inferior vena cava, and coming back as mixed venous blood into the right atrium, through the tricuspid valve, into the right ventricle, finally into the pulmonary valve, and back into the lungs for oxygenation, and to repeat the process. Quite a simple flow and quite beautifully designed. Now the question is, how does that affect our discussion for today? So we'll start off by talking about cardiac hemodynamics. This is quite an interesting aspect of cardiac physiology, because those who really like physics will enjoy the talk on cardiac hemodynamics. It's all about flow. The body is made up of arteries, veins, and these are all pipes. They're not different from a plumbing system. And the key concepts that we normally look at when we're talking about cardiac hemodynamics are velocity of blood flow itself, resistance, laminar turbulent blood flow, compliance, and pressures. So what I'll do right now, because I'll just take you back to the slide above, where I talked about disease physiology, operative physiology, and post-op physiology, is I'll run through these concepts to remind you, because all I'm doing here is reminding you of the things that you studied in medical school. And then finally, we'll talk about its application into our practice. So what is velocity of blood flow? It's basically the speed at which blood flows through the arteries and the veins, and basically the vascular system. And V stands for velocity, Q stands for blood flow, and A stands for cross-sectional area. So we can see that velocity is directly proportional to the blood flow, and this is also inversely proportional to the cross-sectional area of the vessel in question, which then makes you think, okay, which blood flow is faster in what? Arteries or arterioles? So blood flow will be faster in the aorta rather than the smaller arterioles. And why is that? And that's because you have a smaller cross-sectional area, because remember, your arterioles and capillaries, they are small, but they're many of them, right? So if you think about cross-sectional area, we're talking about the total area that they cover. If you were to pull out your capillaries and lay them down, you would see that they constitute a larger cross-sectional area than the aorta, and therefore it's only proceeds from that as a concept that the blood flow will be faster than the aorta. Now, how does this have clinical correlation for us as surgeons? It means that, just very simply, when we're going on bypass, due to the speed of the blood flow in the aorta, it takes a lot of technical skill when cannulating the aorta in the first place, as anyone who has watched or has observed or has done it themselves. And when we're cannulating, we can be thinking about this. Blood flow is the velocity of blood flow in the aorta we'll talk about pressure, is much higher than in other aspects of the system, and therefore you will be thinking to yourself like, well, when I'm putting my stitches, I've got to be very careful. I've got to be very careful when I'm proceeding with this, because this is quite a difficult technical skill to obtain. Then we also think about it in terms of just generally the from the preoperative aspect, is when we move on to what are the pressures in the different vessels in the body. We're thinking about things like the cause of ischemic heart disease, patient with hypertension, for example, high blood pressure, or we're thinking about patients with narrowing arteries, and so on and so forth. Well, why don't I just move on, and then we'll talk about blood flow in terms of output, cardiac output. So cardiac output is, as you moving on to number 2, is a function of pressure gradient, and resistance. Now, the question I would want to ask is, what is pressure gradient, and what is resistance? Pressure gradient, does anyone know? Very quickly, can you post and say and tell me what the pressure gradient we are talking about in this particular formula? Does anyone remember? Okay, so it doesn't seem like anyone's posting this. So the pressure gradient we're talking about will be the difference between mean arterial pressure. Yes, difference in blood pressure, very good. But in this case, if we're being specific, we're talking about the difference in mean arterial pressure and the pressure in the right atrium, right? That's the pressure gradient that we're talking about, because that's what facilitates the flow of blood, the cardiac output through the system. And when we're talking about resistance, what are we talking about? We're talking about the properties of the various vessels. So where do you think resistance is higher? Is resistance higher in the aorta, or is resistance higher in the capillaries? Where do you think resistance is higher? Guess this is quite an easy one, right? Because the answer, yes, well, the answer is in 3. It's right there staring at you. Very good, Nifemi. Because we have the, yes, resistance is higher in the capillaries. Why? Because if we look at the Parcell's equation, and if you're a French speaker, don't come after me for pronouncing it that way. I do not speak French. So the resistance is the resistance in any vessel will be directly proportional to the viscosity, the length of the blood vessels, but will be inversely proportional to the radius. So that means you're going to have high resistance in smaller vessels, right? And so if you have high resistance in smaller vessels, then you move on back to number 2 when we're talking about blood flow. It just means that blood will flow faster in a vessel that has a larger diameter or larger radius, as opposed to a vessel that has a small diameter and smaller radius. And so what, from a preoperative context, again, going back to our clinical correlation, what does this mean? It means that a lot of our diseases stem from this actual fact. So if we talk about ischemic heart disease, the reason why once you have some sort of stenosis or narrowing of the arteries in the heart that feed the heart, you already have a situation where blood flow through the heart itself, that's through the heart muscles, becomes what? Reduced. And now, it's good that capillaries have slower blood flow, because then you're able to have good perfusion and oxygenation of your tissues. However, if you get to a point where the resistance is further reduced, then you have a situation where that blood flow that was optimal even drops and becomes suboptimal. And therefore, you don't have perfusion, you don't have exchange of oxygen. And this is where we then get ischemic heart disease, because then the muscles are overworked. The oxygen demand, when that goes up, the blood vessels are not able to feed and meet that demand. And therefore, you get cellular death, which leads to occur infarction, which obviously leads to death of muscle, and finally heart failure and decompensation. And then you have pressure in the system, in the pulmonary veins, and you go into either acute or chronic heart failure. And in some cases, if the infarction is really great and covers a large area, for example, if it's major left LAD, anterior descending artery, then you have significant infarction of the left ventricle, which could lead to, in a lot of cases, sudden cardiac death. So when you start to, this is what I'm trying to achieve today, to remind you of these principles, but then bring our clinical, what we face clinically, so that we can start thinking about why we do what we do. And therefore, when the resistance goes up in a narrowed artery or vessel in the heart, what do we then do? We go ahead and do a cardiac bypass operation, which was pioneered in the 1970s, if I'm not, 1960s and 70s, if I'm not mistaken, by an Argentinian surgeon. And so this is why we do that, because now we're going to bypass that narrowed artery. Now, obviously, the cardiologists are able to stent, but today we're not talking about the difference between PCI and CABG and which is better and what the latest evidence is. Now, moving on to 4, we're talking about laminar versus turbulent blood flow. This is also an interesting concept. Why? Because blood flow should usually be laminar. If it's laminar, your flow gets to your blood, and the oxygenation that it carries gets to all your relevant areas in the body, so your organs and your brain, your kidneys, and so on and so forth. However, if you have a narrowing of your vessels again, you may have turbulent blood flow. If you have anemia, if you have reduced hematocrit, you may have turbulent blood flow, which does not bode well for oxygenation and perfusion of these end organs. Now, moving on to compliance. Compliance as a concept of hemodynamics. I have written C equals to V over P, and I'm sure I've done this on purpose. I'm wondering if anyone knows what the V is and what the P is. Can anyone, I wouldn't say guess, because I'm trying to remind you of all the things that we studied when we were in medical school. But does everyone remember what this equation is about when talking about hemodynamics and compliance? Okay, so I'm not seeing any answers. So compliance, maybe if I started by saying what compliance is, it may joggle your memory. And so compliance is basically or in some situations we say capacitance, is the ability for a vessel to dilate, right? Okay, and I've written a cheat there by saying greater for veins than arteries. Why? Because arteries are more muscular than veins and therefore are stiffer, right? And so if I've said that, then you can deduce that we are talking about volume and pressure, right? So this is a response of the vessel in terms of their volume that it's able to carry based on the pressure in the system. And so veins do have greater compliance because they're able to dilate once the volume increases. Arteries do have some sort of compliance, however, that's restricted, and that stiffens as we grow older. This is why the older you get, the more likely you are to suffer from high blood pressure as well, because the stiffer your arteries are, the less compliance they are, which means that if there's a volume increase, your arteries are not able to respond as quickly as they normally would do when you're younger. And because of that, the pressure in the system becomes greater, which means that the end organ perfusion pressure is greater than what it should normally be, right? So if you're thinking about an organ that is very sensitive, you're thinking about the kidneys, for example, if there's an increase in the systemic blood pressure, that automatically starts to affect the kidneys as well. And this is why high blood pressure is quite dangerous for kidney health. And there's a direct correlation between high blood pressure and chronic kidney disease. So you have that, keeping that in mind is very important. And also we can talk about other clinical correlations for compliance. We can talk about the use of volume to improve pressure. And we can, and in this case, what will I be talking about? I'll be talking about fluid resuscitation in patients when they've got low blood pressure. However, we also have to remember that if you have a very dilated vessel, the more volume you put in, you will need more volume to achieve a certain pressure. And this is why when we think about things like the post-operative period, when a patient, in some cases, when we have massive release of cytokines and inflammatory markers that cause dilation of our vessels, what do? In order to improve that, we try to vasoconstrict, and we vasoconstrict because if we can vasoconstrict that, we reduce the compliance, which means that by reducing that compliance, we can improve the pressure. As we can see, it's an inverse relationship. Okay, so this is something that I'd like you all to just keep in mind. Finally, we're talking about mean pressures. So we have gone through the basic summary of cardiac hemodynamics. We've talked about velocity of blood flow. We've talked about cardiac output in itself, that's blood flow itself. We've talked about resistance of our vessels. We've talked about how the blood flows. We've talked about the compliance of the vessels and this is based on the property of the vessels that we find. It's different for veins, it's different for arteries, it's different for venules, it's different for arterioles. And then finally, we come to pressures, because we've been talking about pressures, we've not actually spoken or elaborated on that. Mean pressures. So, which is important when thinking about your patient's end organ perfusion, systolic, diastolic pressure, or mean arterial pressure? Anyone with an answer? Which is more important? So you're a surgeon, you've finished your case, you've done triple bypass, you've sent your patient up to ICU, you have all the monitoring kits installed for your patient, and you walk in and your junior calls you and says, I have a problem with this patient, his blood pressure is not really doing well. Excellent, mean arterial pressure. Mean arterial pressure is the most important concept. So I haven't written how you calculate that, but then the question is why? Why is mean arterial pressure the most important pressure, or the most important information that you're looking for? Does anyone know? Just very quickly, if you can write a short answer. Yes, perfect. Okay, excellent. Thank you. So I will just go on and say that, Damilare, you are right on the money. And what we are looking at is something that I've not actually put in this at the moment is called pulse pressure. So pulse pressure obviously is the difference between your systolic and diastolic blood pressure, which you've rightly pointed out, Damilare. And so when we take pulse pressure, the question is, what is pulse pressure? And maybe I can quickly add that here. So pulse pressure. And so that is the difference between systolic and diastolic pressure, which is based on stroke volume. Now, stroke volume is what you the amount of blood that's being pushed out in end systole. Okay, and why do we then focus on mean arterial pressure? Why, someone would ask me, why are we not taking pulse pressure? Pulse pressure is reflective of stroke volume, and stroke volume is the most important concept. Why? Because we want to know how that patient is doing over time. We don't just want a snapshot, right? You've done a 3 to 4 hour procedure, the patient is in ICU, and you're thinking about how long that patient has been doing. So what you want is not just the pressure at one time, you want a pressure over time. And this is what mean arterial pressure gives you, because it's the idea that you are looking at the pressures over a period of time. And for those who are very good at mathematics, if you remember, what you would see on an arterial line is the area under the curve. And if you remember calculus, you'll know that we'll have to calculate the area under the curve to get our mean arterial pressure. And that is what the monitor is doing automatically for you. And that gives you an idea of how well your patient is doing. Okay. Finally, and not only how well your patient is doing, it gives you an idea of the end perfusion, and that helps you regulate with other factors and values, including your central venous pressure, your pulmonary wedge pressure, which I'll talk about, and the overall volume state of your patient. That can tell you what you need to do. Do I need to give more fluids? Do I need to constrict my patient? Do I need to dilate my patient? This is you start thinking about how to manage your patient based on this. So medial arterial pressure is definitely one of the most important concepts in. So now I can write it there because I wanted to ask you all that question. Now moving on, pulmonary wedge pressure. Now, what is pulmonary wedge pressure? And has I'll quickly move on because I think we are running out of time. Someone has posted a question. Okay, in Dr. Addy, some of the questions you're asking may not be topical today, but I'm definitely interested in discussing some of the questions that you've posted. And finally, pulmonary wedge pressure is a way of looking at the pressure in the left atrium. And this gives us an idea of the pressure within the pulmonary vasculature as well. Normally, how we assess this is by putting in a catheter through the IJV all the way down through the right atrium into the right ventricle and up the pulmonary through the pulmonary valves. And we try to wedge that into a pulmonary artery to get the corresponding pressure of what it is, because the pressure in the system usually should be equal across the board, and that will give us an idea of what the pressure is in the left atrium. And this is important because it tells us what our feeding pressures are, and knowing what our feeding pressures are, we can then start to understand whether our patient is well filled, underfilled, or if there's a lot of dilation that's going on, if there's a lot of pressure in the pulmonary vasculature, if we need to, in some cases, diurese our patient, or in some cases, do we need to give more volume? So, these are the overall concepts of cardiac hemodynamics, okay? And so having done that and reminded you all of this, then I'll just quickly go, I'll move on to the next slide, which will just give you a quick overview of what we're talking about with regards to ischemic heart disease, and just pointing out what I said about, you can ignore all the fancy stuff. If you're into ischemic heart disease research, you can take note of that. If you're not, what's most important is we talked about narrowing of arteries. So we talked about resistance. So ischemic heart disease, we're looking at vasospasm in some patients who, there's some patients who have this, there's Prince metal, there's syndrome X, and also a reaction to stenosis as well. You can have vasospasm as well. And in some cases, drugs as well. There are lots of patients who have taken cocaine overdose end up with an acute myocardial infarct. And why does that happen? Because it does cause vasoconstriction and acute vasospasm, which can then lead to large myocardial infarction. We talked about atherosclerosis, again, narrowing of the arteries as per hemodynamics. And again, going back to this, increases the resistance, increases the turbulence of blood flow, it reduces the ability of the vessels, the coronary arteries, to properly perfuse the heart muscle, which then leads to cellular death. Okay, And then we have coronary microvascular dysfunction, which is, and this is occurring in the very small microvasculature. And as we've seen, we've talked about this, in the very small microvasculature, resistance is really, really high, and blood flow is much lower. And if you remember in this Poiseuille's equation, I've not written it, it's 8 times length over pi radius times radius to the power of 4. Therefore, if you have any reduction in this, your resistance is increasing by a factor of 4. So this was just to give you an overall summary of what we've been talking about. Now, moving on to something that I haven't really focused on while we're talking about cardiac hemodynamics, valvular disorders. We have aortic stenosis, aortic regurgitation, mitral stenosis, acute mitral. So I'll just quickly put down here a quick overview of the valvular pathologies that one could have. And very quickly, we'll look at this and quickly go back to 4. So in aortic stenosis, when we have a narrowed aortic valve, while we're expecting, so if this valve over here, you can see my pointer, if that is narrowed, then we're expecting that the blood flow here is going to be more turbulent and coming out at a higher pressure as well, right? And if that's happening, then what we will also expect is that the pressure in the, it takes more pressure in the left ventricle to push blood out into the aorta for the same stroke volume. So if you have a narrowed aortic valve, for the same stroke volume that you're going to be pushing out of that aortic valve, you'll need a higher pressure. To achieve that higher pressure, the left ventricle itself has to, it's basically like going to the gym for the left ventricle. But in this case, it's not very beneficial to the system, because then you get hypertrophy of the left ventricle, and then subsequently you get dilatation of the left ventricle. Okay, and when that occurs and has progressed for quite a long time, we then finally get the symptoms that we've talked about. We get dyspnea, we get angina, and we get syncope in some cases, and we have heart failure. If this is not treated by way of aortic valve replacement, these patients have quite poor outcomes. Now, if we're talking about aortic regurgitation, it's the opposite of that. What is it? It's in this case, this valve has, for one reason or the other, become does not close appropriately, and therefore post-systole you get regurgitation of blood back into the left ventricle, which increases the overall end diastolic volume in the left ventricle. And when that happens, you start to get dilatation of the left ventricle, which then increases the pressure in left atrium, increases the pressure in pulmonary vasculature. In some cases, the patients have, because of stimulation of the J receptors in the pulmonary vasculature, then that stimulates your medulla oblongata, tells you that you have to breathe. That's why patients have dyspnea. And then also, because of the increased pressure, you have increased feeding pressures in your right ventricle, in your right atrium. And what does that lead to? That also leads to pulmonary edema, and worsens the oxygenation of the patient, and therefore we have the symptoms that we've written here in terms of dyspnea, angina, or severe heart failure symptoms. Mitral stenosis, very much the same thing as we've said. When you've got a narrowed mitral valve, you have the same situation where you find it, the left atrium finds it much more difficult in diastole to fill the left ventricle, and therefore you have an increase in left atrial size, and that leads to all the sorts of physiological changes that I've talked about, going into the pulmonary vasculature as well. And then you have decreased exercise tolerance, exertional dyspnea, over probably a longer period than you do for aortic stenosis and aortic regurgitation. And we can go on and on and on with all these different disorders and symptoms. But there you can finally see how an overview of cardiac hemodynamics helps us to understand better the pathologies that we deal with on a daily basis. Okay, so we're going to move to the last physiological concept. I believe I have only 15 more minutes. and this is cardiac electrophysiology. So again, just to go back to the overview of what I've done, we've talked about hemodynamics. I'm talking about electrophysiology now, and again, I'll relate this to our clinical practice. And in module 2, we'll be moving on into things like cardiac output, because I'm sure people are going to ask me questions about cardiac output and the autonomic effects on the cardiac system, and deeper physiological physiology questions. But I will follow this module. That is, we'll talk about a key area, and then I'll link that to all we do in terms of clinical correlation. Okay, so summary of cardiac electrophysiology. We're going to be looking at the electrocardiogram, which a lot of surgeons hate, cardiac action potential, conduction velocity, excitability, autonomic action and heart rate, and conduction velocity. This will, I'll say, form the core concept of cardiac electrophysiology. And if we then move on, we're talking about this. Now, I think I've made a mistake by actually putting what they are here, because it would have been good to just quickly refresh our memory on what these are. But in the interest of time, I won't ask any questions. I'll just move on and provide the answers. So we have the classic PQRS T image here, and we can see that in starting off from P is our atrial depolarization, and it's that which will be the P wave. And so what do we see on an ECG? Why is the P wave important? Now, in any left atrial enlargement, we do see an increase in the size of the P wave. And so this is something to just keep in mind. And then we talk about the PR interval, which is the initial depolarization of the ventricle. That tells us about AV nodal conduction. And so if we're thinking about PR intervals, we know that the normal PR interval is anywhere between 0.12 to 0.2. And so the question is, if you have, if it's much longer, while we were concerned about, then we're concerned about some sort of AV block going on. We know that if we're then going deeper into that, if it's of the first order, then we're thinking about just a lengthened PR interval. And then if we're going into things like type 2, then we're looking at whether or not the interval is lengthened and there's a drop in QRS beat, or whether or not we have just drops in the QRS beat without a lengthening in the PR interval, and so on and so forth. Or if we just have a complete, there's no association between the P wave and the QRS wave, then we're looking at an atrioventricular block of the third order as well. And so if we move into the QRS complex, that tells us what the that's the depolarization of the ventricles. And it's quite interesting when we think about the size of it. The wider the QRS complex, then we start to think about bundle branch block, because widened QRS is telling us that the conduction is being delayed through the protein fibers. Okay, and we can then start thinking about why we have either a left or a right bundle branch block. And if we have both of them in a patient, then we have a full atrioventricular block. And the question is, what are we going to be doing with our patient? And in that case, that will be when we're calling for pacemakers, putting a pacing system to help with our patients, ensure that our patient is able to have a normal cardiac cycle. And then this is an error. It's not OT, but QT. The QT interval is the entire period of the depolarization and repolarization of the ventricles. That's very important from a clinical perspective when we're thinking about the effects of certain drugs. So you would see that in a lot of cases, or pharmacists will tell you that the medication you're about to prescribe, for example, if you're giving a patient ondansetron or cyclizine, which is an antiemetic, and the patient is already on some cardiac medication, they'll tell you things like, oh, your QT interval has been increased, and then they're very concerned. And why are they concerned? Does anyone know what happens when our QT interval is lengthened? Can anyone post very quickly? Well, we can have an arrhythmia called torsades de pointe. So that's one of the reasons. Yes, perfect, Emma. Excellent. So we can have that. Do you know what the treatment for that is? Well, we're going deeper. There's no real need for that. Anyone know? Dr. Addy, some of the questions actually all the questions you're posting are not related to our discussion today. I'll really appreciate it if you either focus on the topic today or you allow those who would like to answer some of the questions or ask their topical questions to do so, please. Okay. So moving on, we're talking about ST segment. The ST segment shows depolarized ventricles, and finally the T wave shows ventricular repolarization. Now, what's important about the ST segment? Well, we all know about STEMI, and we all know about NSTEMIs. And the simple thing to say is, if you have a STEMI, you have a bad situation. Why? It means that your the whole of your myocardium has been affected. Thank you for your apology, Dr. Andy. The whole of your myocardium has been affected by whatever ischemic event you're having, and that has now shown in problematic depolarization of your ventricles. Usually that would show in an elevation of the ST segment starting from point J, which is usually about 0.01, if I'm not mistaken, from that beginning of the S, where I've just put my pointer, and you'll see quite an increase there in your ST segment, and that tells you, and then depending on your leads, on your ECG, I have not included, yes, you do treat torsades de pointe with magnesium, excellent. And obviously, if the patient goes into VF or VT and becomes unstable blood pressure wise, or has then gone into cardiac arrest, you're not going to be using magnesium anymore. You're just going to be shocking the patient with a defibrillator. So well done, Isra. So talking about the ST segment, if you're looking at the different leads, so either V1 to V6 or you're looking at 1 to 3 or AVF and AVL, a combination of these leads will tell you where your infarction has happened. And I wish I could have talked a bit more about ECGs, but I know when you start talking about it, you have to keep going deeper into the subject to elicit greater understanding. But the most important thing to remind you about is this is the basic cycle, and that denotes depolarization, repolarization, and finally just some clinical correlates for you to remember why this is important. Okay, so for this, I was hoping to go through 20 slides, 23 slides actually. I'm just on number 10. I have a hard stop for 7 o'clock, so we will continue this next week, Monday. Well, that's if you all think this is useful. And so just you let me know, and you let me know also in terms of the information. Am I giving too easy information? Am I giving do I need to explain a bit more so that I do understand where to focus on during my next presentation? Okay, finally, everyone knows what this is. This is an action potential, but this is a trick one. Which is this, atrial or ventricular? This picture I've shown So is this of the sinoatrial node, or is this of the cells you would find in the ventricle? Does anyone know? Can anyone post? Okay, so this is typical action potential that you'll see in the ventricles. Okay, yes, perfect, Isra. So this will be typical that you'd. And I've started with first because before talking about the pacemaker cells, I'll just want to briefly remind you all about the most important thing, which is the action potentials going on in ventricles, because it's the contraction of the ventricle that actually then pushes, or should I say, is the most important part of our cardiac cycle. Right. So you remember that in the in this action potential, we always start off with the membrane potential, which is the equilibrium, which is always based on the resting membrane potential is very close to the potassium equilibrium, and that is the flow of potassium ions either into or outside the cell, and so this is usually negative. Right. Now, depolarization occurs when you have a signal from the pacemaker cells, and then they go all the way into your ventricle. What are they actually doing? They're stimulating rapid depolarization of that membrane potential, which occurs by moving that membrane potential from negative, which normally is an average of negative 90 minus 90 millivolts, all the way to the positive potential, which is plus 52, usually on average. But the key thing here is that this happens quickly. That's the key thing about depolarization, that it's happening quickly. It's not a slow process. That is this phase. And this is caused by influx of sodium into the cell through the membrane, which makes it more positive. And then finally, you go into phase one, which is a transient fight to get back into equilibrium. And that is when you have more positive ions, which is potassium, going out. And then what you then have is you then have calcium coming back in and saying, okay, no, even though potassium is going out, I'll come back in to maintain this potential, right? And that's where you get to phase two of your and that plateau. And then finally, we have depolarization, repolarization, which happens when calcium stops maintaining that positive potential and starts to decrease. And then the potassium current starts to increase as well. Outward current starts to increase, trying to bring that membrane back to its negative potential. And it's very important that it brings it back to phase four, which is negative potential, because when it's repolarized, then you can have a further depolarization again of the cell. So this is how you get your action potential, which then leads to contraction of the myocardium. Now, a very quick word on pacemaker cells. So we know that the pacemaker cells are found in the SA node, and the reason why this is the case is if you look at this, and I don't know if I can. It's not very clear. I just seeing that now. You can see that they are constantly in a situation where they want to, where they're less negative than your ventricles, than the cells in your ventricles. So they achieve the push to a positive potential much faster than the cells in your ventricle. However, one of the things that are that's very important to remember is that when you have a situation where you have an SA node failure, and where your pacemaker cells are not doing what they're meant to do, for example, an ischemic disease where you have problems with your right coronary artery, which has that small angular artery that feeds the SA node just at the proximal bit. If you have proximal stenosis, then that means that you're more likely to then have problems with your sinoatrial node, with your pacemaker cells. And what usually happens is you get sick sinus syndrome, you get bradycardia. Why? Because your SA node is no longer beating at that 70, 75, 80 beats per minute. and your action potential is now being driven by your ventricle, which is between 50 to 60 or beats per minute. So then you have your AV node taking over the pacemaker function of the heart. So always remember that even the ventricles themselves can, on their own, be pacemaker cells in the event that there's a sick sinus node when your actual pacemaker cells are not depolarizing as they should. Okay, we stop here, and it just tells me that we'll start earlier next week because we will now have some of the issues we had today, and we'll just quickly go through the last bit of conduction, velocity, excitability, and autonomic action on the heart. And then I'll go into just discussing the clinical correlation with regards to the most important thing in surgery, which is putting our patients on a bypass, talking about drugs that affect cardiac action potential. I may, if we have time, show a quick video of a CBD circuit. We'll talk about cardioplegia, which helps stop the heart during surgery, and how it works by its actions on the cardiac potential. We'll talk about pacemakers as well, just very briefly. And finally, we'll talk about drugs that we use in ICU and how they affect this parasympathetic and sympathetic function. And finally, we'll just go through a routine post-operative management of a patient, just reviewing everything we've talked about in the last 2 slides. And then if we finish that next week and Nifemi is kind enough or there's demand, then I'll move on to module 2 where we'll go deeper into cardiophysiology. Unfortunately, I can't take any questions today, but I do hope this was useful for you all. If you can leave me some feedback so that I know how to tailor the lecture further next week, Monday. Okay. Nifemi, this is over to you. I'll stop sharing my slides.
Thank you very much, David. That was a very interesting teaching. I hope everyone found it insightful. And as I said, the next session, this module 2 on the cardiac physiology, we'll be taking it next week, Monday. But before that, I just want to just make an announcement. There is the third session of the teaching, which was already scheduled for Saturday rather, which will be if you look through the SIGAF page, you see the announcements. The session is already there, so you can sign up for that session. It's going to be on aortic disease and aortic surgeries. So feel free to sign up for that while we will be taking the second session of the second module for the cardiac physiology on Monday next week. So 15th Saturday will be aortic diseases, and 17th will be the second session on the second module on the cardiac physiology. So feel free to sign up for those sessions. They're on the SIGAF page. And thank you everyone for coming. If you have questions from today's session, just note it down, and I'm sure David will be glad to answer them next week when we come back. And thank you very much, David. Thank you, everyone. Don't forget to fill your feedback form. I've put it on the chat. Fill it. You'll be able to get your attendance certificate on filling that, and it will also help to see how better um, we can we can make the session better. Thank you, everyone, and see you hopefully on Saturday for the aortic disease session. Thanks, everyone.
And thank you, Nifemi, for everything. Cheers, guys. I'll be awaiting your feedback, and please leave feedback so that I can tailor this better to meet your expectations and your needs. Okay. Do have a lovely week ahead. Bye.
Bye, guys.